My name's Bob Wells. For those of you who don't know me, which is probably most of you, I recently joined the Sax Institute, although probably still in the process of joining the Sax Institute. So it gives me great pleasure for so early in my life, if you like, at Sax to host one of these forums. I won't bore you any more about me, and I'll move quickly now to introduce Cliff Hughes, who's the chairman, CEO of the Clinical Excellence Commission, and Cliff's going to open our proceedings tonight. Thanks, Cliff.
Thanks, Bob. Yes, can I also extend a welcome to you to the 9th HARC Forum. It seems only yesterday that we started talking about what we were going to do with this alliance between the Sax Institute, a bunch of highly professional academic theoreticians in system management, the ACI, a bunch of highly refined clinicians doing models of care, and the CEC, a grab bag of people from all sorts of areas trying to drive the system. That's not what I really think, but I have to say that. But it really is a matter of bringing health system managers and clinicians and researchers and indeed the community to look at issues of common interest. And medical errors are a particularly important issue for our system. I'm not sure how many of you had the opportunity to watch 60 Minutes last night and see that horrific story about the Air France plane that disappeared on the way to Paris. Incredible story. But it really began because they failed to diagnose the problem. And from that point on, they were unable to correct it because everything they thought about just didn't fit with the paradigm that they thought existed. And catastrophe, and people died unnecessarily, including the 3 pilots who just simply got it absolutely wrong. Now, we know what that's like. If you're going to put your hand up and say, I don't know what that's like, then you're not working in the health system, because it's a very difficult place to work. Because once we make the diagnosis, our treatment, our prescription, our surgery depends on the paradigm that we've developed, and we very often develop in a way that's unshakable. But we know that errors occur, we know that mistakes occur, we know that we're fallible, and we need to look at why those things happen, and we need to research the human factors behind it, the environmental factors behind it, and also develop actions to enable us to compensate for our failure occasionally to make diagnostic errors. The HARC Forum actually is not an accident. It came out of a vision that we thought was really important in New South Wales to bring together members from different parts of the system to drive system change for the improvement of quality of care and for patient safety. And that's what we really hear about. This particular forum is really interesting because we bring another expert to the table to help us deal with this very basic issue of diagnostic error. And I note the title, What Can I Do? This is not remote from me. It comes down to us as individuals. I hope that researchers will learn about studies that investigate the causes of diagnostic error from the point of view of human or cognitive function. I hope that will lead for opportunities to adapt studies and methodologies to the Australian system so that we conduct new research and explore new areas for learnings. On the other hand, clinicians and health system managers will have a chance to learn the state of the art about knowledge on the causes of diagnostic error. And we do need to listen and to learn from the experience of others, often who are more experienced than us, but also who make and have experienced diagnostic errors. How often have we heard it said when somebody, quote unquote, confesses to something that wasn't quite right, that so many people in the room admit to having been in the same situation themselves and not knowing what to do, just like those pilots last night. So clinicians will listen and learn what leads to diagnostic error, and hopefully also learn solutions that have been tried elsewhere that improve not only safety and quality, but efficacy and effectiveness of care. And that really sums up what the forum is all about. So I'm glad that you're here tonight. We've also got an expert panel, which Bob will introduce later on, who will guide your discussion and your learnings around the process. But of course we need to have leaders if we're going to learn and if we're going to follow. And this evening we are very privileged to have one such leader in our midst, and he sits to my left here, and that is Dr. Mark Graber. He's a senior fellow at RTI International and Professor Emeritus of Medicine at the State University of New York. He has a background in biomedical and health services research with many, over 70 in fact, peer-reviewed research publications. He's a pioneer in efforts to address diagnostic error in medicine. His research in this area has been supported by the US National Patient Safety Foundation, and I hope the New South Wales community groups as well. It's also been supported by the Agency for Healthcare Research and Quality, an organisation well known to many of you in this room. In 2008, he convened the Diagnostic Error in Medicine Conference Series, and in 2011 founded the Society to Improve Diagnosis in Medicine. He has a huge range of appointments, honours and awards, which I'm not going to go through today because they'll buy into his much more valuable dissertation on reducing diagnostic error. What can I do? Would you please welcome Mark to the podium?
Thank you, Cliff, and thank you, Bob. It's really a pleasure and an honor to be here. It's my first trip to Australia. I'm loving it tremendously, and it's a real adventure for me. Pretty good with email. If anybody would like to correspond and send me comments, I'm at mgraber@rti.org. I'd like to accomplish a couple things with you tonight. I'd like to talk about how big a problem is this? How do these diagnostic errors arise? And what can I do as a physician, a policymaker, a leader of a healthcare organization, as a patient? And I suspect many of you in the audience wear a couple of these hats, so you're going to leave with a much longer list than others. And it's a research forum, so I'm going to focus from a research perspective. What do we know and what do we need to know? And for those of you in the audience who are serious researchers, my apologies, you're going to be very disappointed. This is a young field. We have basic methodologic issues that we have yet to work out, as you'll see soon enough. So diagnosis is important to me as an internist. We view ourselves as the ideal diagnosticians. It's the most critical of a physician's skills. It's every doctor's measure of his abilities. It's the most important ingredient in his professional self-image. Also important to our patients. The mystery to me, if it's so important to all of us, why has it been not discussed for so long? We've been doing diagnosis for 2 millennia, and yet nobody's really had a discussion about how good do we do? Can we do any better? And tonight is dedicated to that kind of a talk. So what are the major research issues in terms of how big a problem is this? Well, first we need a definition of diagnostic error. And then we need to know how we can measure the incidence of diagnostic error in actual practice. So let's start with the problem of how you define a diagnostic error. And I apologize, we don't have a standard diagnostic error definition to give you. There are several of them out there. The one I use is here at the top. I say it's a medical diagnosis that's wrong or missed or egregiously delayed, but you require a gold standard to say that. My definition was based on that, adopted by the Australian Patient Safety Foundation. It's worked for me, but if you don't have a gold standard, it's not going to work. So other definitions have cropped up. Gordy Schiff uses the definition shown here. It's a mistake or failure in the medical diagnostic process. So the emphasis is on a breakdown in that process. Hardeep Singh has his own definition. He defines it as a missed opportunity and requires a judgment that adequate information was present to suggest the final correct diagnosis at an earlier date, et cetera, et cetera. The emphasis is on that missed opportunity. And Laura Zwan goes back to first principles, the definition of reason at all. It's a failure of a planned action to achieve the desired aim. So these are all out there, and depending on your interests as a researcher, one of these will suit you better than others. And at the moment, we can't quite reconcile them all. We do seem to agree on this bit at the center here. We all seem to agree that it's all about wrong and missed and delayed diagnoses. But don't bother figuring out which of those it is, because there's a lot of overlap. And if there's an opportunity for research here, it's in regard to what do we mean by a delayed diagnosis? What does that mean exactly? How long does it take on average for physicians to diagnose your heart attack or your cancer? How long should it take? And I'd like to think that we're at the start of those kinds of efforts to begin to lay those out. Where the definitions digress is up on the top part there, because Gordy Schiff would say it's all about an error in the process, the left-hand upper corner there. And I'm worried as well about the no-fault conditions, where the disease presented at too early a stage for anybody to get it correctly, or it was silent entirely, or presented atypically. So Gordy would say those are not diagnostic errors, but to me that's where medicine will advance over the next decades. We'll have new tests that will make that breast cancer that we can't see today, we'll be able to see that in 10 years because the instrumentation is better. So that's a very important group, and I think that's how diagnosis will improve going forward. We also all agree that once an error happens, they don't always lead to harm. In fact, probably most diagnostic errors don't. They're inconsequential, or we catch them in time. So we don't really know what that balance is. The best guess at the moment is it's about 1% of the diagnostic errors will lead to serious harm. What we do know derives from a wide range of studies that I'm going to go through with you in a little bit of detail because really it's all we have. We start with surveys. Arthur Elstein gave his own personal opinion about this. Arthur is a cognitive psychologist from Chicago. He studied how doctors think his whole career. That was his research focus. And it was Arthur's estimate that we were wrong 10 to 15% of the time in our diagnoses. Seems like a really crazy high number, but the longer I'm in this field, the more I'm convinced he was pretty much on target. There have been many patient safety surveys. This is one from the Isabel Healthcare Foundation. They found that 1 patient in 3 related a diagnostic error that affected themselves, a family member, or a close friend, and the diagnostic error is the greatest fear of patients encountering the healthcare system. There are also surveys of physicians. Hardeep Singh did a survey of pediatricians. 54% said they had made a diagnostic error themselves at least once a month. Poon and colleagues found that 83% of primary care physicians reported at least 1 unacceptable delay in seeing abnormal test results in the previous 2 months. John Ely reported 202 reports from family medicine doctors. He asked them, well, what did you learn from your diagnostic error encounters? And they said, well, the most common thing that we didn't do correctly was to do a broad differential diagnosis. And in Hardeep Singh's study, if you go back and look at those, in the diagnostic error cases that he identified, 80% of the time, if you looked in the medical record, there was no differential diagnosis at all. Case reviews is another way to look at diagnostic error and try and get some feeling for the incidence. And there are literally hundreds of these types of studies where you pick a particular condition and you look back to see how did we do. And the answer uniformly is we don't do too well. So how about cancer-related spinal cord compression? Well, in 319 patients, the median delay was 18 days. It's a condition where you need to make the diagnosis immediately to prevent permanent disability from spinal cord compression. And it's on and on and on in any particular disease you'd like to look at. Unacceptable delays are routinely encountered. And we all know that diagnostic errors account for a great many malpractice suits. This is information from CRICO RMF. It's the insurance company for the Harvard teaching hospitals in Boston. So they're insuring a group of very elite physicians who practice the highest quality of medicine. And even amongst this group, the claims for diagnosis far outnumber all the other claims combined. It's a little different in Australia. You have, I think, a better balance, but in the States, diagnostic error by far leads the pack. Reports from physicians through voluntary portals provide us a very unique way to look at diagnostic errors. Just to give you a little background, we all travel on airplanes routinely now, and we do it with most of us a feeling that it's going to be a fairly safe trip. And it's thanks to the aviation safety reporting system in large part. This is run by NASA in the United States. They collect voluntary reports from pilots, from mechanics. Anybody can report to the ASRS. And they study these. They analyze what went wrong. They try and fix the problem, and it's applied throughout the industry. So can't we do that in healthcare? Okay, you've made a tremendous start in Australia through the APSF. It's been the model that the rest of the world has tried to emulate. But I have to tell you that in the States, the experience has been very disappointing. Physicians in particular are reluctant to disclose their own diagnostic errors. And in fact, the system that we set up in my healthcare system, the VA healthcare system, was patterned after the ASRS. It's a beautiful system. You could report things anonymously. No one would ever know it was you. We set it up so that it was easy. There's forms on every ward, in every clinic. You could do it online. Tremendous failure. We got very few reports. I think in an average year, we got 10 reports from physicians. And the system was closed a few years ago as a result. Hospitals use a wide range of tools to look at adverse events and quality problems. Many of you may have heard of the IHI Global Trigger Tool. It's meant to detect all the never events that we don't want to happen at all in your hospital. There's 15, 20 different items on there. Not a single one of those captures diagnostic error. And none of the tools in routine use are very good at this. There was a report from Sang et al. Who looked at all the existing quality assessment tools available, and none of them captured diagnostic error effectively. A report from Levinson from the Medicare system in the United States looked at 785 Medicare inpatients, and they found a high rate of adverse events amongst this population, 13%. It's right in line with all the studies that have been done in many different countries using 5 different quality assurance approaches, but not a single episode of diagnostic error. So the tools we use now are just not good. Chart review. Can't we just start looking through the charts? That's exactly what Hardeep Singh, I've mentioned his data already. And what they have found is that 1 in every 1,000 primary care encounters includes a missed diagnostic opportunity that could have prevented serious harm. So you can find errors by going through charts, but you have to look through a lot of charts. How about autopsies? Great way to learn. Kaveh Sojania surveyed the literature in 2002, reported a 25% incidence of major discrepancies that would have changed how the patient was managed, potentially would have changed the outcome. Study was just published last year by John Winters from Hopkins Hospital. They looked at errors involving the intensive care unit and found 31 studies, 8% incidence of class 1 and 15% incidence of class 2 errors. So these are lethal or potentially lethal errors that would have resulted in 36,000 deaths a year in the ICU in the United States. And also based on autopsy data, Leap, Berwick, and Bates calculated that this would account for 40,000 to 80,000 deaths a year annually in the US from diagnostic error. And if I've done my math correctly, it would be about 2,000 to 4,000 cases per year in Australia. What's very interesting from the autopsy data is this kind of study. As you know, the incidence of doing autopsies is going down universally. We do almost none in the States, and I think the trend is similar here. And one reason that's often quoted is that, oh, I know why my patient died. I don't need to do an autopsy. So this was a study that looked at that. It was a study in Slovenia. They autopsied everybody who died in the intensive care unit, 270 patients, and they asked the physicians to rate their degree of certainty about the diagnosis. How sure are you about the cause of death? And what they found was that the physicians who were completely certain about the cause of death, completely certain, were wrong at exactly the same incidence as the physicians who had minor or major uncertainty. So the conclusion is we really have absolutely no idea about whether our conclusions are correct or not, and how certain we are about what happened or how correct our diagnosis may be is probably baseless. So this is the pyramid that we now are starting to talk about. There's this huge number of cases of diagnostic error that's happening throughout our primary care practices, our specialty practices, our inpatient practices, and it results eventually in 2,000 to 4,000 deaths per year. The problem with this is that all the studies I've shown you are research studies. None of them are measuring the rate of diagnostic error in actual practice. So I can't tell you my own rate of diagnostic error. I can't tell you your rate. I don't know a single healthcare system in the world that's measuring the rate of diagnostic error in their own healthcare system. Okay, so let's summarize what we've learned. We have a wide range of research approaches that have been used. The incidence is probably high. It's probably 10%, and some small fraction of these errors result in serious harm or death. But what we need to know is the incidence in actual practice, and no one is measuring that. What I'd like to discuss briefly are some possible ways we could start measuring, and there are several possibilities. Trigger tools, that's what Hardeep Singh is using. So we already talked about the fact that he can go through all these hospital records or patient charts and find some diagnostic errors, but you have to go through quite a few. So what Hardeep has come up with are what he calls trigger tools. And the trigger is whether you've been to a general medicine, a primary care visit, and then you're admitted to a hospital within the next 2 weeks. So if you just look at those charts, you tremendously enrich the odds of finding a diagnostic error. In his studies, it was a 21% incidence of diagnostic error versus just 2% in unselected patients. And this is where this number comes from, of 1 in every 1,000 primary care patients experiences a diagnostic error. Another sobering finding from his study is that almost all these involve very common conditions. Diagnostic errors involving anemia, dementia, heart disease. It's not exotic diseases that are being misdiagnosed, it's really every disease. Another approach that I think we'll see a lot of, and I would like to see researchers starting to use more, is what we call standardized patients. I'm not sure what the term would be here. It's like a secret shopper. So you train an actor, or you actually have a patient who has like something classical, COPD, rheumatoid arthritis, and you send them out into practices and you see how the doctors do. And what's found is that there's a diagnostic error rate of about 13%, right in line with all the other studies we've been looking at. Kind of a shocking finding from these kinds of studies is reported by Schwartz recently, 399 visits to 111 doctors, but if you look through the medical records, you would have a hard time finding the diagnostic errors that they know occurred because they knew the diagnosis of the patient they sent into the practice. So the doctors are not doing a good job documenting their thinking, they're not doing a good job writing it down, and if you had relied upon medical record review to find the diagnostic errors, you would have missed a lot of these. So it points out a major weakness in just using the medical record to identify diagnostic errors. Maybe we could do a better job getting the doctors to tell us about diagnostic errors, and there's some very encouraging news from Robert Trowbridge. He works in a medical center in Maine in the United States. And Bob just went around to his friends. He's a hospitalist. He works in the hospital. And he says, I'm interested in diagnostic errors, and I want you to tell me the ones that you encounter. And I'll come by once a week and just tell me those patients. And it worked. His friends trust him. They know he's interested in these things. It's a blame-free environment. He established a desktop icon, and they can click on that if they like. They identified 36 diagnostic errors over a 6-month period. And in most hospitals in the United States, you would identify 0. So just by saying, I'm interested, I want to know, tell me your cases, they were very successful. And I also think our patients would be happy to tell us the diagnostic errors that they themselves encounter. Weingart et al. Studied 228 discharged patients. They identified 20 adverse events, 13 near misses. None of these had been detected by the standard quality assurance tools used by the hospitals. And similar reports are coming out from many different countries. So if you ask the patients, I think we could call them a week or two after their admission or a week or two after they've been seen in the emergency room. Hi, how are you? How you doing? Did we get the diagnosis right? So our challenge is to measure the incidence of diagnostic error and harm in actual practice. We need to do it routinely. We need to do it reproducibly because you can't improve what you can't measure. And research is all about measurement. We have to learn how to measure. Let's talk a bit about how these errors arise. And okay, diagnosis is tough, absolutely. I think it's the hardest cognitive challenge that humans encounter. We talk about rocket scientists. I think what doctors do in the process of diagnosis is more challenging than that. The the uncertainty that surrounds the diagnostic process is just unbelievable. There's so little we know about what the patient is actually experiencing. And we don't have complete knowledge ourselves, and there's so much complexity in our healthcare systems. It's just really difficult. And how many diseases are there? There's two ways to count. The World Health Organization tells us there's 12,420 as of the latest ICD-10 version. The National Library of Medicine compiles these under their mesh headings, and they say there are 8,000 diseases out there. How many diseases does the average doctor see in a year? 50, 100, 200? How good are we going to be at diagnosing those other 7, 8, 10,000 that we don't routinely see? And the problem is this isn't a static number. This number is changing all the time. There's 200 new mesh diagnoses added every year. Did you know about the yellow nail syndrome? How about the alien hand syndrome? How about the Donahue syndrome? How about the cryoporin periodic syndrome? So this is just 4 out of the 200 that were added last year. So it's hardly a static problem we're dealing with. This is the system I use to understand how diagnostic errors arise. So here's our patient going along their clinical course, and there's a bad diagnostic error. There will always be somebody right there at what we call the sharp end. And if it's my patient, it will be me. And we're talking now about the cognitive errors that I've made. Why didn't I get the diagnosis correct? But what the Institute of Medicine would say is, you know, don't bother with you. Let's think about our healthcare system. That's where the money is. Because if you can fix something in the blunt end, in the system-related contributions to diagnostic error, you've done the world a real favor. You've decreased the odds of having that same diagnostic error in the future for everybody. So that's where we should put our money. I believe what they say, but as a physician, I spend a lot of time thinking about the cognitive errors too, because that's under my control. So I'll talk a little bit about both. I had a research opportunity to study 100 diagnostic errors, and this is the final breakout that we found. Most commonly, there were elements of both system problems and cognitive errors in the cases. If you ask how often is a cognitive problem there, well, you have to add up the blue and the yellow. It's like 75% of the time there's a cognitive issue. How often is there a system problem? It's the blue and the red. So 2/3 of the time there's a system issue. What kinds of system errors are we talking about? Well, no surprise, communication and coordinating care. It was the top in our study. It's at the top of practically every patient study that you see. It's just really hard to coordinate care, and it's getting harder all the time given the complexities of our healthcare systems. Expertise needs to be available when it's needed. We have many breakdowns in alerting physicians to abnormal lab tests. We don't do a perfect job supervising our trainees, so this goes on and on. The one that worries me a lot is the one at the bottom, this normalization of deviance. When we studied the hospitals, we found that the exact same error would be happening in that hospital over and over and over. And they'd just gotten used to it. That's just the way it is. And I think that's kind of a universal problem and a universal concern. Okay, how about the cognitive errors? I was actually happy to see that knowledge deficits weren't really a huge problem. Medical school works. Our training programs work. It's a little disappointing, 14% incidence of faulty data gathering. We could do a better job with our histories, our physical exams, making sure we're ordering the right tests and interpreting them appropriately. But the money is in putting it all together. That's where the dominant problems arise, faulty synthesis. And it gets into the issue of how doctors think. We have to understand that if we're going to understand those breakdowns in synthesis. So this is the kind of thing that Arthur Elstein studied, how do doctors think? Hasn't got it all figured out, but he's made some progress. He simplified the question. You know, do doctors think? Cognitive psychologists thought we would solve problems in some normative fashion, in some ideal fashion. We would make a nice list. We'd make a big, broad differential diagnosis, and we'd think about the odds that each one of those could possibly be the case. We think about the consequences of getting it right or wrong. And we'd combine all these in a statistically appropriate fashion to come up with the best diagnosis. And is that what we do? Absolutely not. How many of you are familiar with the dual process model? Okay, some, not all. All right. Well, this is the current paradigm, we think, of how doctors think. Most of the time, we recognize what's going on immediately. It's a matter of pattern recognition. And we use what we call system one. It's really just our intuition. We know what's going on. We recognize it. We understand it. And instantaneously, within milliseconds, we have a diagnosis. So that's system one. If that's not the case, if we don't recognize it, if things don't fit, if they don't make sense, we resort to system two. This is the deliberate, rational consideration of what might possibly be going on, that ideal system that the cognitive psychologists would like us to use, but we seldom do. So here's a nice example. What if we were seeing this patient, 64-year-old male, he's got Hodgkin's disease, he's doing okay, nicely treated, but he comes in with this wicked rash on his back. It's vesicular. What does he have? Got shingles, right? Okay. Now, did you know that because you're a dermatologist? Any dermatologists in the room? Not a one. Yeah. But we can make this diagnosis, and it took us exactly 50 milliseconds to do it. And that's how we do most of our cases. It's called the availability heuristic. And all that means it's right there at the front of our minds. We recognize this. We've seen it before. We may have had it ourselves. And it's a wonderful way to solve problems. It's how experts solve problems. It's fast, it's effortless, it's almost always correct. Because we've seen it so commonly, because it's so common and the base rate is so high, so the odds of it being correct are high. But it's got drawbacks, like every heuristic that we use in medicine. It's not perfect. And what are the drawbacks? Well, we're not constructing a broad differential. Our experience is limited. We may not have seen some of the other things on that list. And just because it's available doesn't mean it's correct. It could easily be something else. And we're also too vividly biased by some big case that we encountered. We had a resident at our hospital who, we had a patient come in with, seemed like pneumonia, fever, cough, chest infiltrates. We thought it was a community-acquired pneumonia. He made the diagnosis of sarcoidosis, and he was right. And he was very proud of it, and we were very proud of him for having made the diagnosis. And all was well until the next patient came in with pneumonia. And what did he have? You know, he really had pneumonia, but he thought he had sarcoidosis because it was right there, you know. So that's a problem too. I'd like to tell you about a case of diagnostic error that we had in the States. It made all the newspapers. It kind of the basis for the next few slides. So this was a young boy, 12-year-old, Rory Staunton. His father told us this story at our diagnostic error conference last year. Very unusual 12-year-old boy. Most 12-year-olds in the States are playing video games and skateboarding. But Rory read the news, and he was worried about civil rights in North Korea. And he had started a no bullying campaign in his school. He was very impressed with Sully Sullenberger, the pilot who landed that plane after the birds got sucked into the engines on the Miracle on the Hudson. He had written a letter to Sully Sullenberger. He wanted to be a pilot when he grew up. Well, that's not going to happen. He had scraped his arm in gym class, and 3 days later woke up in the middle of the night and told his parents he felt really sick. He had a fever, was kind of shaking, and he threw up. Big mistake. The next day he felt worse. He got taken to see his pediatrician, had fever, he had tachycardia. The pediatrician noted that he had modeling of his skin. We don't have a picture for me to show you, but that's what the physician saw. And he thought that, okay, you have fever, you're throwing up, you have gastroenteritis. Makes sense. And thought the boy needed to be rehydrated, so sent him to the local emergency room. Turned out to be the emergency room at one of the best hospitals in the country. In fact, if you read their advertising in the newspapers and in the magazines, they say they're in the top 5 hospitals in our country in terms of quality and safety. So this is the emergency room he went to, and they looked at him and said, yep, fever, throwing up, gastroenteritis. They gave him a liter of fluid and sent him home, but he died 2 days later of strep sepsis. So how would we analyze this case? This is kind of how I would look at it. Let's think about the system errors that might have gone wrong. Turns out his white blood cell count was elevated and didn't come back while he was in the emergency department. Came back a couple hours later. It wasn't outrageous. His white blood count, I think, was 14,000. So it should have been, 8 or 9. I'm not sure if that would have changed anything, but it is a system error. They didn't have a good plan for follow-up. They didn't tell him, okay, if you're not better tomorrow, come back. The family had no idea what to do if he got worse, which he did. And what's very disappointing, they had no system to learn from this error. The only thing they changed was, okay, we're going to have a rule, nobody leaves the emergency department until their tests are back. Great. I'm happy that they did that. I'd have been happier if they had said, we're going to study diagnostic errors because these happen commonly and we're going to try and learn as much as we can. That did not happen. And what they didn't address at all are the cognitive errors that were so obvious in this case. And if you think about it, we break it down into these three things. Did they know about sepsis? Sure, all the emergency doctors know about sepsis. How was their data collection? Well, it could have been better. They could have waited for that white blood cell count. But they put the case together completely incorrectly. When the pediatrician called them and said, I'm sending over a boy with gastroenteritis, they should have said, don't tell me that. Don't tell me a diagnosis. I want to figure it out myself. Instead, they were completely biased by the frame that the pediatrician gave them. They didn't think it through independently. They saw somebody who had thrown up and they're thinking GI problems, so gastroenteritis made all the sense in the world. And they committed a crime that's very common in the diagnostic error world. We call it premature closure. It means they stopped thinking. The minute they had solved the puzzle, the minute they came up with a diagnosis that fit all the pieces, they were happy. And that's how we all work as human thinkers and human decision makers. We have very busy lives and we have all sorts of challenges in front of us. And the minute we solve the problem, we're moving on to the next thing. We don't stop and think, gee, I wonder if there's a better solution than the one I already came up with. What is a mountain goat doing way up here in the cloud bank? You know, if you look at aviation disasters, and Cliff gave us an excellent example there, this happens over and over again. The pilot thinks the autopilot is engaged, and it's not. They think they have enough fuel to get back to the airport, and they don't. They think there's no ice on the wings, but there is. They think the patient has gastroenteritis, but they're in a completely wrong context. What is this middle symbol? Well, in the top line, it's a B, and it's in the bottom line, it's a 13. Context is everything. Pat Crosscarry has a really nice article on that if you'd like to explore that in more detail. Context is everything. And premature closure is a concept that Herbert Simon won a Nobel Prize for as an economist, this concept of satisficing. So as human decision makers and as doctors, what we'd like to see is that we optimize. We use those normative techniques. We construct that complete differential diagnosis. We think about all the possibilities, especially the serious ones. That's not what we do. We satisfice. We come up with the first thing that solves our problem, and we're happy and we're moving on. Anybody own a dog? Any dog people out there? Yeah. How'd you get your dog? Did you go look at 5 litters? No. We go and we look at 1 litter, we fall in love with some puppy, we are done, we're happy. That's how we are as humans. We satisfice. So all this is about system 1. It's about using our intuition. And there are problems with using our intuition. I'd like to show you a few of these. Many of you are sitting with your legs crossed. No good. Please uncross your legs. Sit up straight. Okay, now what we're going to do is this is kind of an exercise to see how good your cerebellum is. You make nice, smooth circles with your right foot. That's it. Make a pointer. Okay, and draw the number 6 in the air. Okay. Can you do that? Can anybody do that? Funny things happen to our foot, right? So this is our autonomic brain operating. We have really no idea why that goes astray. We were doing such a nice job making circles, and the next thing you know, we can't do it at all. We have very little insight into this. Okay, here's a quiz question for you. You'll probably know this because in the States, nobody has a clue, but how long is an Asian elephant pregnant for? Anybody know? 24 months. Okay, but pretend it's a quiz. And what advice were you given? We've all taken lots of these multiple choice questions. Were you told to trust your intuition, or were you told to go back and check your answers? Trust my intuition? How many? Hands? How many go back? Really? Okay. Well, a mix. We just completed a study of this. We'll look at the bottom line there. We looked at the test that's given to internists to become board certified. It's the most important test a physician can take in the States. It uses realistic case scenarios, and we looked at the 80 questions on there that have to do with diagnosis. We picked 500 residents at random. So we looked at 40,000 questions, and it's on the computer. So you can see when they go back and change an answer. And what we found is that in the yellow there, sometimes they change a wrong answer to a wrong answer. Okay, that doesn't really help any. But you're twice as likely to change a wrong answer to a right answer than vice versa. It's beneficial to go back and the ones you're unsure about to rethink it. It's twice as good. And what I didn't know when I did the study, I should have done my literature search first. I did it second. This is the exact same finding 7 other times over the last 80 years. And not only is it qualitatively in the same direction, it's quantitatively. And every one of these, it's about twice, or sometimes even a little better, twice as likely to get it right if you go back and rethink it. So this notion we have that our intuition is so reliable is suspect. And I think it's not a great way to make a diagnosis. And I think whenever you have time, you should really stop and think, how did I come up with this diagnosis? Should I trust my intuition? So what have we learned? How do these errors arise? They arise because diagnosis is tough. Cognitively, it's difficult. We're faced with the complexity and imperfections in our healthcare systems and our fallibility as human thinkers. From a research perspective, what we need to know is, do most errors arise from system 1, like I'm trying to sell you, or system 2? That's a valid research question, I think an interesting one. How do we assess competency in clinical reasoning? Right now, all our medical education throughout the world is based on assessing our medical knowledge. And we do a good job with that. I've already shown you that data. But that's really not what doctors do. Doctors need to function with that knowledge. They need to do clinical reasoning well and competently, and I want to be able to measure that. How do we assess calibration? So I want to go see a doctor who not only has a lot of knowledge and they're good at clinical reasoning, I want a doctor who knows his limits or her limits, who kind of has a sense for what they know and what they don't know. Because if you have that sense, that means you'll know when to slow down. You'll know when to rethink a case. You'll know when to get a consultation or go research it further. Let's finish up with what I can do. Hardeep Singh and I just did a systematic review of these things. Hardeep focused on the system things and I focused on the cognitive things. And we have a major problem, just getting started here. Nobody is rushing forth to address the problem of diagnostic error. There's a serious ownership issue here. If you talk to somebody running a hospital today in any country, they'll say, oh, you know what? My agenda's full. I have plenty of problems. If there's a diagnostic error, go talk to the doctors. They're the guys making the diagnoses. Not my problem. All right. I go talk to the doctors. The doctors say, you know what? I can't remember the last diagnostic error I made. Can't remember. Oh yeah, a couple of years ago I made a diagnostic error. So the doctors think it's not their problem either. We know that they're out there. We know that there's malpractice suits. We know that diagnostic errors happen. We may have made one ourselves once or twice, but we all basically think, way down at the bottom, it's the other guys. It's the guys at the other hospital, at the other city who aren't as careful or not as competent as I am. So doctors have an ownership issue here too, and educators similarly have no feeling that this is something they need to deal with. If you talk to a microbiologist, he says, I want to teach microbiology. I'm a nephrologist, I'll go teach nephrology. Nobody wants to go teach diagnostic errors. So we have to get over that ownership issue. All right, let's talk about what physicians can do. I've already shown you a list of all the system problems that can happen. Well, a short list of some of the system problems that can happen. I think doctors have a responsibility to bring those to attention. I think you should talk to the people who run your hospitals and say, you know what? I didn't get my x-ray reading back for 3 days and I needed it yesterday. That's a problem. So we need to do a better job with that. I think we could do a better job getting feedback. You know, that's how people become experts. They get feedback. They get a lot of feedback. They learn from the feedback. How much feedback do we get as physicians because we're no longer doing autopsies? What if we gave permission to our colleagues to tell us about our diagnostic errors? What if our emergency department doctors gave permission to the doctors on the wards? If I admit a patient and I had it wrong, let me know. I'd like to learn from that. Pat Crosscarry, if he were here, would say we need to learn about the dual process model, that if you really understood all the things that can go wrong with intuitive thinking, with system 1, we wouldn't make those mistakes so often. That might work. I don't know. I'm kind of a bigger fan of these last two things. I'd like to see physicians be more reflective, be more comprehensive, to construct that differential diagnosis more regularly. And there's some tools coming online, I'd like to show you them, where we could get help, second opinions, get help from decision support resources. So what can we do cognitively? Well, there's really three things. We could learn more. We could become more expert. Nice solution, takes years. So it's not something we can do tomorrow. Well, what can we do tomorrow? Can we improve clinical reasoning? Can we get help? And I think there's some hope here. I've tried to show you the breakdowns that can happen with system one thinking, using our intuition, these problems with context errors, with premature closure, with the heuristics that go awry. It turns out, luckily, that some of the solutions, really any of these on the right, would solve all the ones on the left. So if you just pause to reflect, or if you use the universal antidote, consider the opposite. These would be very effective ways to combat all of these problems over on the left-hand side. Be comprehensive. Use the crystal ball exercise. You may not have heard of that one. It's from the military. So they're trying to train the low-ranking guys, we call them privates, to be the next, like the sergeant, the next rank up. So they're giving them an exercise to do. You have 500 men and 2 tanks and 2 helicopters. Come up with a battle plan to capture that hill that's defended by 1,000 men, but they only have 1 tank. So the privates come up with a battle plan and they turn it in, and the guy running the drill looks at it as a great plan, but I have a crystal ball, I can look into the future, and your plan didn't work. You didn't think it through enough. Come up with plan B. And after going through this a cycle or 2, they learn to have plan A, but to think it through a little bit more detail and have plan B. Any of you who play bridge? Any bridge players left in the world? Yeah, a few. So if you're a bridge player, you know all about plan B. If my finesse doesn't work, what's my plan going to be? We need to do this as physicians. We need to look into the future. What if my diagnosis isn't correct? That I was in the wrong context? Did I have premature closure? How can we be more comprehensive? Well, there's some real simple tricks. ROWCS, rule out the worst case scenario. It's a mnemonic that all the emergency doctors learn. Vitamin C, C, and D, I'll show you that in a minute. NYD is kind of my favorite. This is from Canada. Not yet diagnosed. I love it. If you're a doctor in the emergency department, you haven't quite got things figured out, NYD. Much, much better for that patient. More safe than writing down, I think it's gastroenteritis. Because the next doctor, they'll look at it, oh, gastroenteritis. Okay, I know how to treat that. NYDs, we need to keep thinking about that patient. And there's some electronic tools coming up. I'll show you those. Here's vitamin C, C, and D. We have this on the wall, on the ward in my hospital, so the students can look at it. So after they thought through, all right, is it cardiac, is it gastrointestinal, they can go through this kind of list. It's a different way of thinking through a patient problem. Maybe it'll jog your thinking a little bit. Maybe using a checklist would work. John Ely has composed a series of these for all the major complaints that you might see in general practice. They're available online at this website. You can come and get it from me afterwards. So if you look up feeling cold, well, gee, sepsis is right there on the list. And here's some web-based systems that are available for use. DXplain, Isabel. There's one for dermatology that's really superb called Visual DX. This is how Isabel works. So you can go online and you put in the key findings in the case. So here I put in, if you look down on the left there on the bottom, I put in fever, mottled skin, and vomiting in an older child. And what comes up, number 3 on the list there, is group A streptococcus, toxic shock syndrome, sepsis. So had they used one of these electronic tools, they might have made the diagnosis in Rory Staunton's case too. There is some research on using Isabel. This is an example. It's not easy to study diagnostic errors because fortunately they are kind of unusual. But this was done in a pediatric ICU. They're looking at all the kids who've come in who haven't had a diagnosis yet. And the residents on their own got it right 89.4% of the time. Using Isabel went up from 92.5%, got their attending in there even a little better. So you can look at that and say, well, that's not much of a change. Only went up 3 points. But I look at it the other way. I look at it and I say, okay, there was a 10% error rate of those kids coming into that ICU, and they cut it down 30%. So that's 3 kids who are going to avoid having a serious diagnostic error. And I'll take that any day. That's how we have to start thinking as physicians. Okay, we have to do these things to get the next couple percent. We probably do really well now. If we get it right 90% of the time, great. How do we get to 95%? This is a second opinion. I thought you had something else. Let's talk about second opinions. We know second opinions work. Radiologists, if a second radiologist reads the mammogram, 2 to 4% discrepancies discovered. Same in pathology, same in dermatology. There's a company in Boston called Best Doctors, and this is what they do. They provide second opinions for patients who want one. And what they find is that 29% of the time, there's a diagnostic error in patients who come to them questioning their diagnosis. And I love their slogan, you know, has your diagnosis had its checkup? All right, what can I do as leader of a healthcare system? Well, how about starting by measuring the rate of diagnostic error in your hospital? How about creating space to talk about diagnostic error? How about having an M&M conference, an open discussion about the next diagnostic error that comes through? How about starting to work on all those system problems that we know contribute to diagnostic error? How about providing some of these decision support resources? Isabel, DXplain, they're not that expensive. How about pathways for feedback? How about making it easier to get a second opinion or get access to the experts? Some things that are already in progress. Hardeep Singh, I mentioned his name a couple times. He uses electronic medical tools to study diagnostic breakdowns. This is the kind of thing that you could do at your hospital. They look at how often critical alerts. So the lab finds potassium of 8. You have to get hold of the doctor. Your patient's got a potassium of 8. How many times do those things succeed in reaching the right person and evoking the right response? 10% error rate in communicating critical abnormal alerts. Michael Kenner at Kaiser Permanente Healthcare System has used their electronic medical record system to look at all sorts of things. Positive PSA where the doctor hasn't done anything else. Positive fecal occult blood where no colonoscopy's been requested. Overdue lab tests, overdue colonoscopy follow-ups, many different things. He's identified over 2 million opportunities to avoid diagnostic error just using these electronic tools. How about policy people, if you're involved in policy making? What I'd like to see you do is start addressing this issue of ownership. Somebody's got to take ownership of this diagnostic error problem. How about setting a goal for diagnostic reliability? How about requiring reliable communication of test results? In the States, this is the one thing that the Joint Commission requires to recertify your hospital. They see if you have a reliable system in place to communicate those test results. That would be a good place to start. A dashboard might be very valuable. A dashboard about, are hospitals looking at this? Are you having discussions? How about facilitating dialogue and research on diagnostic error? Educational programs that emphasize diagnosis and calibration. You know, and at the end of the day, we're all going to be a patient in somebody's office or in some hospital. So what can we do as patients? Or what advice should we give our patients now? I think great advice is to be a good historian. If you think that the medical system is doing a great job keeping track of all the things you've told us, you're wrong. Patients would be well served to keep their own record of what's happened to them and what tests were done and what consults they've had. Take advantage of cancer screening. Absolutely, would save a lot of diagnostic error. Speak up. I would like to give patients permission and encourage them to ask, what else could this be? It seems a little fresh, but it might get the doctors thinking a little bit more deeply, a little bit more comprehensively. Ask how to get back if things aren't going well. How do I get back to you if I'm feeling worse? When do I get back to you? And if they do encounter diagnostic error, I'd like them to tell me about it. I'd like to find out. And really good advice, if you get septic, don't throw up. That was Rory Staunton's mistake. So where are we? Well, we're not in a good place. I'd like to think we know where we are, and it's not where we want to be. We want to be in some better world where diagnostic errors are less frequent and less harmful. But we have to start somewhere. We have to start from where we are, and we have to envision where we'd like to be. Where should you start in Australia? Where that's up to you to discuss. I think you should start thinking about where these errors occur in your healthcare systems and when and how often. I'd like you to start thinking about how you could do a better job finding these errors and trying to understand them. Maybe we're talking too generally. Maybe we should talk more specifically about a given disease. Okay, coronary artery disease. What are the pitfalls in making those diagnoses? If we did it one disease at a time, maybe that would be a better approach. And we need to start measuring and studying these interventions that I've been talking about. They're all right now just ideas, just hypotheses. We think they should work. Seems like a good idea. Somebody has to test them and evaluate them in practice to see what actually comes out. So what do we know? Well, we know that diagnostic error represents an enormous challenge to high quality and safe patient care. And what we need to know is how to raise awareness about this problem, how to begin changing our healthcare systems and our educational systems, how to change physicians' perspectives and behaviors. And we need to know who's going to take ownership of this issue and when. And I'd like to believe that it's going to be you and I who take ownership, and then we're going to start right now. Thank you.